Bronchiectasis. Ectasis means dilatation. So bronchiectasis means bronchoalveolar dilatation. It is an obstructive lung disease. It lies within a disease spectrum of chronic pediatric suppurative lung disease. Bronchiectasis is characterized by irreversible abnormal dilation and anatomic distortion of the bronchoalveolar tree. It represents the common end stage of many non-specific and unrelated antecedent events. Females are affected more frequently than males, and the most common cause for bronchiectasis are cystic fibrosis in developed countries and Mycobacterium tuberculosis in developing countries. So overall, cystic fibrosis and the Mycobacterium tuberculosis are the most common causative agent for bronchiectasis. When we see conditions that predispose to bronchiectasis in children, from the proximal airway narrowing, airway wall compression, airway intraluminal obstruction, and airway stenosis and Malaysia are common causes. From the airway injury, bronchiolitis obliterans, which can be post-viral or after lung transplantation, and recurrent pneumonitis or pneumonia. From altered pulmonary host defenses, cystic fibrosis, ciliary dyskinesia, impaired cough, for example, due to neuromuscular weakness conditions, and altered immune status, such as primary or secondary abnormality of the immune system, and other causes such as allergic bronchopulmonary aspergillosis, plastic bronchitis, and right middle lobe syndrome. Three basic mechanisms are involved in the pathogenesis of bronchiectasis. The first is obstruction. Obstruction can occur because of tumor, foreign body, impacted mucus because of poor mucociliary clearance, external compression, and bronchial webs, and also atresia. The other is infection. Infection caused by different bacteria and the virus are a risk factor. The third is chronic inflammation. This is similarly contributes to the mechanism by which obstruction leads to bronchiectasis. Both inadequate and exaggerated or dysregulated immune responses may play a role in the development of bronchiectasis. The common trait in the pathogenesis of bronchiectasis consists of difficult clearing secretion and recurrent infections. This vicious cycle of infection and inflammation resulting in airway injury and remodeling. In early stage, bronchiectasis consists primarily of bronchial wall thickening and destruction of elastin resulting in bronchial dilation. In later stage, the bronchial walls develop cartilage destruction with associated pulmonary artery and arterial vascular remodeling resulting in pulmonary hypertension. Bronchiectasis can manifest in any combination of three pathologic forms, best defined by high-resolution CT scan. The first is in cylindrical bronchiectasis. In this case, the bronchial outlines are regular, but there is diffuse dilation of the bronchial units, and the bronchial lumen ends abruptly because of mucus plugging, which gives the shape of cylindrical shape. The second is in varicose bronchiectasis. In this case, the degree of dilation is greater, and the local constrictions causes an irregularity of outline resembling that of varicose vein. The third is in saccular or cystic bronchiectasis. In this case, the bronchial dilation progresses and ends in ballooning of bronchi that end in fluid or mucus-filled sacs. This is the most severe form of bronchiectasis. Pre-bronchiectasis is when there is chronic or recurrent endobronchial infection with non-specific high-resolution CT scan changes, and in this case, it might be reversible. This is the first stage of development of bronchiectasis. The second is high-resolution CT scan bronchiectasis. In this case, clinical symptoms with high-resolution CT scan evidence of bronchial dilation, and in this case, it may persist, progress, or improve and resolve. The third is established bronchiectasis, like the previous, but with no resolution within 2 years. Early diagnosis and aggressive therapy are important to prevent the development of established bronchiectasis. So, early diagnosis and aggressive therapy are important in the earlier stage, in the pre-bronchiectasis and the high-resolution CT scan bronchiectasis stage. After that, after it's established bronchiectasis, there is no complete cure or resolvement. Regarding clinical manifestation, on history, the most common complaints in patients with bronchiectasis are cough and the production of copious purulent sputum. Younger children may swallow the sputum, and hemoptysis is seen with some frequency. Fever can also occur with infectious exacerbations, and anorexia and poor weight gain may occur as time passes. On physical examination, typically reveals crackles localized to the affected area, but wheezing as well as digital clapping may also occur. In severe cases, dizziness and hypoxemia can occur. Pulmonary function studies may demonstrate an obstructive, restrictive, or mixed pattern. When we came to the diagnosis, conditions that can be associated with bronchiectasis should be ruled out by appropriate history, physical examination, and investigations. On chest X-ray, chest radiographs of patients with bronchiectasis tend to be non-specific. Typical findings can include increase in size and the loss of definition of bronchovascular marking, crowding of bronchi, and the loss of lung volume. In more severe forms, cystic spaces occasionally with air fluid levels and honeycombing may occur. Compensatory overinflation of unaffected lung may be seen. The other is CT scan. Thin section high resolution CT scanning is the gold standard because it has excellent sensitivity and specificity. CT provides further information on disease location, presence of mediastinal lesions, and the extent of segmental involvement. The lower lobes are most commonly affected in bronchiectasis. When we came to treatment, the initial therapy for patients with bronchiectasis is medical, and the aim is decreasing airway obstruction and controlling infection. Airway clearance techniques, antibiotics, and the bronchodilators are essential. 2 to 4 weeks of parenteral antibiotics is often necessary to manage acute exacerbation adequately. Exacerbation can be defined as the presence of two major criteria, one major and one laboratory criteria, and one major plus two minor criteria. There are major criteria, minor criteria, and laboratory criteria. So based on those criteria, if we have two major criteria or one major and one laboratory criteria and one major and two minor criteria, we can say there is exacerbation of bronchiectasis. Antibiotic choice is dictated by the identification and the sensitivity of organisms found on deep throat and the sputum or bronchoalveolar lavage fluid culture. The most common organisms found in children with bronchiectasis include strep pneumonia, non-type Babelech influenza, Moraxera catarrhalis, and the Mycoplasma pneumonia. Amoxiclavulanic acid, which has been particularly successful at treating most pulmonary exacerbation, is used to treat this exacerbation. Long-term prophylactic macrolide antibiotic or nebulized antibiotics might be beneficial, but may also increase antibiotic resistance. So we should have to consider the advantage and the side effect of giving long-term prophylaxis. Airway hydration by either inhaled hypertonic saline or mannitol also improves quality of life in adults with bronchiectasis. Any underlying disorder, immunodeficiency or aspiration that may be contributing must be addressed. When localized bronchiectasis become more severe or resistant to medical management, segmental or lobar resection may be needed. Children with bronchiectasis often suffer from recurrent pulmonary illness, resulting in missed school days, stunted growth, osteopenia, and osteoporosis. Earlier recognition or prevention of predisposing conditions, specialist multidisciplinary management, more powerful and broad spectrum antibiotics, and improved surgical outcomes are likely reason for improved outcome nowadays. This is all about bronchiectasis. Thank you for watching.